Hello everyone. We learned the anatomy, imaging, and spatial examinations of the hip joint in the last lesson. Today, we will begin to learn about specific orthopedic disease of hip joint. I hope everyone can combine the previous knowledge and master it comprehensively. First, let's look at the femoral neck fracture.
Femoral neck fracture refers to the fracture between the femoral head and the base of the femoral neck. Femoral neck fracture often occur in the elderly and more women than men. The angle formed between the femoral neck and the femoral shaft is called the inclination angle, also known as the neck shaft angle. And the normal value is between 110 degree and 140 degree. Neck shaft angle greater than normal is coxa valga, and smaller than normal is coxa vara. The angle formed by the line between the central axis of the femoral neck and the midpoints of the two condyles of the femur is called the anteversion angle and is normally between 12 degree and 15 degree. When treating femoral neck fracture, we must pay attention to maintaining a normal colodiaphyseal angle and anteversion angle, otherwise it will affect the function of the hip joint. The blood supply of femoral head and neck mainly comes from three ways. First, the small arteries of the articular capsule come from the anastomosis of the medial femoral circumflex artery, lateral femoral circumflex artery, inferior gluteal artery, and obturator artery. They are the mainly blood supply to the femoral neck and most of the femoral head. Secondly, the nutrient artery of the femoral shaft only reaches the base of the femoral neck. Thirdly, the ligamentum teres artery only supplies the blood supply of the inner and lower parts of the femoral head. Therefore, the blood supply of the femoral head mainly depends on the blood vessel of the articular capsule and the round ligament. Due to the poor blood supply of the femoral head and neck, fracture, non-union, and avascular necrosis of femoral head are prone to occur. Secondly, let's look at the etiology and pathogenesis of femoral neck fracture. Elderly patients with femoral neck fractures usually come from no-energy injuries, which can be direct or indirect violence. Direct violence includes direct impact on the greater trochanter when falling or lateral rotation of the lower limbs when falling and the femoral neck impact behind the acetabulum. Indirect violence is usually a fracture caused by the contraction force of the muscle at the attachment point being greater than the force that the femoral neck can load. Femoral neck fractures can be divided into two types according to X-ray imaging: adduction and adduction. Abduction fractures often occur when the hip is abducted, and most of them are fractures below head. The fracture ends are cut into each other, and the inclination angle formed by the fracture line and the vertical axis of the femoral shaft is often less than 30 degrees. The local shear force of the fracture is small, and the blood supply is less damaged, so the healing rate is relatively high. The adduction fractures generally occur when the hip joint is adducted, and most of them are fractures in the middle of the neck. The inclination angle formed by the fracture line and the vertical axis of the femoral shaft is often about 45 degrees. The strong shear force at the fracture site and the disrupted blood supply cause high rate of avascular necrosis of femoral head. Clinical adduction fractures are more common, while abduction fractures are rare. In addition, there is another classification called Garden classification based on the degree of fracture displacement. It is commonly used by scholars domestic and overseas. Type 1. Incomplete fracture or abduction impaction fractures accompanied by a certain degree of femoral retroversion. Type 2. Complete but non-displaced fracture. Type 3. Complete fracture with partial displacement, abduction of femoral head, slight upward movement of femoral neck and lateral rotation. Type 4. Complete fracture and complete displacement, and the femoral neck is obviously moved upward and lateral rotated. After femoral neck fracture, the common symptoms are: first, deformity. It shows mild hip flexion and knee flexion, lateral rotation deformity, 45 degree to 60 degree. Secondly, pain. It shows local tenderness and positive longitudinal percussion pain. Third, swelling. Most of them are intracapsular fractures, and the swelling is not obvious. Fourthly, dysfunction. Patients are generally unable to stand and walk. Fifthly, the affected limb is shortened. The physical examination should focus on whether the pelvic separation squeeze test and lower limb rolling test are positive. For patients with suspected femoral neck fractures, X-ray should include anterior, posterior, and lateral view of femoral and the anterior posterior view of the pelvis. For patients without displacement or femoral neck compression fractures, reconstructed CT can make a better judgment. MRI examination is only suitable for patients who cannot determine whether there is a fracture of the femoral neck. Finally, the treatment of femoral neck fracture. The goal of most femoral neck fracture is to achieve early motor function after treatment, reduce the incidence of long-term bedding complications, and improve the patient's functional prognosis. For non-displaced or impact fractures, the injured limb can be placed in abduction with knee joint slightly flexed, foot in neutral position, and then fix the fractures. During the fixation period, the patient should be instructed to do 3 not to do. That is, not cross-legged, not lying on the side, and not bearing weight. Surgical treatment is still the gold standard for the treatment of most femoral neck fractures. Generally, for patients with femoral neck fractures, the operation is required to be completed as soon as possible to reduce perioperative complications, improve patients' comfort, and reduce hospital stay. Next, let's talk about hip dislocation. Hip dislocation is commonly seen in young people with strong mobility, mostly due to strong violence. Both direct and indirect violence can cause dislocation. According to the anterior and posterior position of the femoral head between the anterior superior iliac spine and the ischial tuberosity after dislocation, it can be divided into anterior dislocation, posterior dislocation, and central dislocation. Posterior dislocation is more common in clinic. First, the posterior dislocation, mostly due to indirect violence. When the hip is flexed at 90 degrees, medial rotation and adduction of femoral shaft is performed excessively. If it is subjected to a violent action on the lower back, the femoral head can break through the articular capsule and protrude out of the acetabulum, resulting in posterior dislocation. The femoral head that is dislocated backward and upward can compress the sciatic nerve, causing corresponding movement and sensory disorders in the affected limb. Secondly, the anterior dislocation. When the hip joint is extremely adducted and rotated laterally due to external force, the femoral head is pushed out of the acetabulum due to leverage, forming an anterior dislocation. After dislocation, if the femoral head stays at the level of the pubic branch, it is a dislocation of the pubic bone, which can cause femoral artery and vein compression. If the femoral head stays in the obturator foramen, it becomes an obturator foramen dislocation, which can compress the obturator foramen nerve. Thirdly, the central dislocation. When violence acts on the greater trochanter from the outside, it can be transmitted to the femoral head and impacted the bottom of the acetabulum, causing a fracture of the bottom of the acetabulum. When the violence continues, the femoral head can be displaced into the pelvic cavity together with the fracture block of the acetabulum, becoming a central dislocation. Or when the hip joint is a mild abduction position, an external force along the longitudinal axis of the femur can also cause central dislocation. Central dislocation can inevitably cause fracture of acetabulum. After the dislocation occurs, the common symptoms of injury usually appear, that is, pain, swelling, and dysfunction. However, due to the different position of the femoral head after dislocation, the clinical manifestation of the three dislocations are different. First, the posterior dislocation. The injured limb shows typical deformity include flexion, adduction, medial rotation, and shortening. The knee of the affected side is tightly attached to the thigh of the unaffected side and is elastically fixed, which is called sticky knee sign positive. The raised femoral head can be touched on the hip. X-ray examination can be observed that the femoral head is located outside and above the acetabulum. Secondly, the anterior dislocation. The affected limb is typical deformity of abduction, lateral rotation, and mild flexion, and is longer than a healthy limb. The knee of the injured side cannot approach to the thigh of the unaffected side and is elastically fixed, which is called sticky knee sign negative. The femoral head can be touched before the obturator or near the inguinal ligament. X-ray examination can be observed that the femoral head is in the obturator foramen or near the superior ramus of pubis. Thirdly, the central dislocation. The affected limb will be shortened and the greater trochanter is not really touched. If digital rectal exam is performed, the injured side is always painful. Finally, let's look at the treatment of hip dislocation. Clinically, anterior dislocation of the hip joint occurs less frequently and the reduction is easier. Traditional Chinese medicine can be used to reduction. The patient is in supine position. One assistant fixes the pelvis. The other assistant holds the lower leg, bends the knee to 90 degrees, slowly abducts the hip, rotate it laterally and flex it. The performs traction in the direction of deformity so as to separate the femoral head from the obturator foramen in the superior ramus of pelvis. The surgeon stands on the opposite side, holds the upper thigh with one hand, presses outward and downward, and pushes the femoral head in the acetabulum with the other hand. At the same time, the surgeon adducts the affected limb under traction. When the bouncing sound of femoral head is heard, it is reset. If manipulative reduction fails, early open reduction and internal fixation should be done. Manipulative reduction should be performed immediately for fresh posterior dislocation of hip joint. Commonly used clinical reduction methods include hip flexion and extension method and rotation method. If manipulative reduction fails, open reduction and internal fixation should also be done as soon as possible. After successful reduction, skin traction or bone traction should be adopted for fixation. Posterior dislocation generally maintains abducted hip joint in a 30° to 40° neutral position for 3 to 4 weeks, and anterior dislocation is maintained in an adduction, medial rotation, and extension position for about 4 weeks.
Well, that's all for this lesson. I hope you can actively review it after class. Thank you.